Hello, and thank you for joining this session as part of the webinar series with the Canadian Spondyloarthritis Association. This webinar and patient forum is on the topic of axial spondyloarthritis, AxSpA. My name is Brenda Delodder, and I'm the Executive Director with the Canadian Spondyloarthritis Association. And I am delighted to be the moderator for today's event. I'm really excited to be here with you all today. We have people joining us from coast to coast across all the time zones from this amazing country of ours. And I'm pleased that we are, we were planning on being broadcast live in both French and English, but as I said, we are having some technical difficulties with the French, so that will be provided probably within the next 2 days or so for those who have registered en français. I do want to provide a trigger warning, as there may be some images, some commentary, some comments, some dialogue that can be difficult for some. And if this is the case, please be mindful of what you personally need if this does arise. And we understand and value that triggers are very individualized. Spondyloarthritis is a complex condition and quite often debilitating, as we all know. It is the most prominent form of inflammatory arthritis in the country, and it affects more than 500,000 Canadians today. And the Canadian Spondyloarthritis Association was struck by patients and is the only patient-led charitable organization solely focused on Canadians living with spondyloarthritis. And we really work hard to provide credible and valuable and relevant resources such as this annual forum here today. So thank you for joining us in conjunction with the Spondyloarthritis Research Consortium of Canada on this very important topic. And we have experts on this panel who are leading the presentations and the dialogue. I would like to begin by acknowledging the Indigenous peoples of the lands that we are on today. While we meet today on a virtual format, we do take a moment to acknowledge the importance of the land, which we each call home. I come to you from Hamilton in Ontario, which is part of the treaty lands and territory of the Mississaugas of the Credit. Today, we recognize that those joining are doing so from across various lands and territories. For thousands of years, Indigenous peoples inhabited and cared for these lands and continue to do so today. We are grateful to have the opportunity to work and to live on this land, and by doing so, give our respect to its first inhabitants. I also wanted to mention that the information provided today by the CSA and by SPARCC is not designed or intended to constitute medical advice or to be used for diagnosis purposes. Due to unique individual needs and medical history, please consult your own healthcare provider, who will be able to determine the appropriateness of information for your specific situation and can assist you in making decisions regarding treatment and medication. The next few slides, I have the privilege of introducing our expert guests here with us today. And thanks to those who have submitted questions in advance. We will be getting to as many questions as we can today. We will focus on moving through those previously submitted questions, and then we're going to do our very best to get to all of those questions that are put in the Q&A function, which is seen at the top of your screen today. It is my pleasure to introduce Dr. Robert Inman. Dr. Inman completed his undergraduate degree at Yale University and his medical degree at McMaster University. He did his training in internal medicine at Vanderbilt University and his fellowship in rheumatology at the Hospital for Special Surgery in New York. He completed a research fellowship at the Hammersmith Hospital in London. He then moved to the University of Toronto, where he was appointed professor in the Department of Medicine and Immunology. He is currently co-director of the Schroeder Arthritis Institute, co-director of the Spondyloarthritis program at Toronto Western Hospital, and deputy physician in chief for research at University Health Network. He is also an executive of the Spondyloarthritis Research Consortium of Canada, which we call SPARCC. I also welcome Dr. Nigil Haroon to our expert panel. Dr. Haroon is the head of the Division of Rheumatology at the University Health Network and Sinai Health. He is an associate professor of medicine and rheumatology at the University of Toronto and a senior scientist at the Krembil Research Institute and the Schroeder Arthritis Institute, which is a state-of-the-art research facility in Toronto. Dr. Haroon is an internationally renowned clinician scientist in the field of axial spondyloarthritis, AxSpA or AS. He is well published in the area and has been an invited guest speaker in several international meetings. Dr. Haroon also served on the board of the Spondyloarthritis Research and Treatment Network, as well as the medical and scientific advisory boards of the Spondyloarthritis Association of America and the Canadian Spondyloarthritis Association. Dr. Haroon has won several awards, including the Vanier Scholarship and the Jane Bruckle Award of the Spondylitis Association of America. And finally, I also wanted to mention one of our expert advisors, Laura Passalon. Many of you know Laura as an expert at this annual event. Laura is not able to join us here today, but has contributed significantly to today's content. Laura obtained her Bachelor's of Science in Physical Therapy from the University of Toronto and completed a Master's of Health Science in Epidemiology and Community Health at the University of Toronto. She is a certified advanced practitioner in arthritis care. Laura's research focuses on the rehabilitation and the education of spondyloarthritis, as well as innovative health sciences delivery by rehabilitation professionals. So Laura is a lecturer at the Department of Physical Therapy, Faculty of Medicine at the University of Toronto, and works as a physiotherapist practitioner with the arthritis program at Toronto Western Hospital. So thank you to our three incredible experts. Please really accept our gratitude for being with us here today.
Good evening, everybody. Thank you all for joining. A pleasure always to be back and present on AxSpA. So today I will be talking mostly on pathogenesis and the early stages of presentation and diagnosis, and Dr. Inman will be following with how we treat patients with ankylosing spondylitis and the recent advances. So let me share my screen 1 second. Very good. So the whole idea is answering the question, is it in my genes? What actually causes ankylosing spondylitis or axial spondyloarthritis? So the outline of my talk is mainly discussing on the genetic causes of AS. In the beginning, we'll talk about HLA-B27, a gene that most of you would know. Cover a little bit on the non-HLA genes and then go on to non-genetic factors. And at the end, hopefully we'll have time to cover the clinical presentation of axial SPA. So axial SPA and AS, as it is popularly known, is really caused by a complex network of cells and molecules. But we don't really know the root cause of AS till date. It's been over 50 years since the discovery of HLA-B27 and the identification that genetic factors do play a role, but yet we don't exactly know how the disease is caused, what are the key genes. But clearly, genetics appears to be the predominant cause and some influences from the environment. The earliest clues came from family studies and twin studies. If you look here is a study of 6 monozygotic twin pairs and 20 dizygotic twin pairs. So this means that these are monozygotic pairs, almost identical twins, and dizygotic means they have some gene sharing, but they are not identical, right? And this number here refers to the number of times or the percentage where if one twin is affected, the second twin is also affected with AS. And you can see if they are monozygotic twin pairs, greater gene sharing, 50% concordance of disease, as opposed to only 20% concordance. So only 2 out of 10 twins, if they're dizygotic, would have disease in both twins. Okay, so that clearly shows that if you have greater gene sharing, higher likelihood of the disease occurring in both individuals. So probably genetics has a role. Similarly, if you look at the degree of relationship within a family and the concordance of disease within the family, as you go from third degree of relationship to second, first, and twin, you get closer and closer with increasing gene sharing. Let's look at how the concordance goes. Clearly, with twin, it's 50 to 60%. First degree relatives are around 10%. So if you're asked the question, if there is one member in the family, what is the chance that another first degree relative within the family will be affected? First degree relative means, if you're for parents, it will be the kids, siblings, parents. So all these are first degree relatives. First degree relatives is 10% chance only. So if you look at the flip of that math, 90% chance that another person within the family will not get the disease. So, and the same number, 90% chance that the next generation or the kids will not get the disease. Okay, so what's up with this HLA-B27? Let's look at how a normal immune response happens. Okay, so this is an antigen presenting cell, and antigen presenting cells function in our immune system to present to our army of immune cells if something extraneous enters the body, because a virus or a tumor is not good for survival. So the antigen presenting cells would capture this. And here I've given an example of a virus. The antigen presenting cell has captured the virus. The virus is composed of many proteins. The immune system cannot really look at the entire organism like that. So it has to be broken down into individual components and proteins and peptides, which ultimately become antigenic or elicit an immune response. So how does it elicit an immune response? Each of these components has to be presented by the antigen presenting cell on a plate to our immune system. And our T cell within the immune system can come, recognize this combination of the antigen on that plate and recognize it as self or as foreign. If it sees that it is just a thyroid antigen, the immune system does not cause any issues. It goes on as normal. Now, in an autoimmune situation, of course, the antigen may be abnormal, and then you get thyroiditis and hypothyroidism and things like that. So HLA-B27 essentially is this hand that presents antigen to our immune system, so that our immune system, our infected cells can be killed, and our survival is increased. So that is HLA-B27. It's actually a great gene. It's a great molecule, and the gene behind its B27 gene is a great gene. And why I say that is because those who are HLA-B27 positive, if they get hepatitis C virus infection, there is a lower chance of them developing cirrhosis, because the hepatitis C virus can be presented like that beautifully on B27, and our immune system can try and get rid of it, or at least keep it under check. Similarly, HIV patients who are HLA-B27 positive tend to have less chance of progression to AIDS. So progression of HIV virus infection is also lower because B27 has the ability to present HIV antigens to our immune system, so our immune system can keep it under check. So actually, it's a very good gene. Unfortunately, HLA-B27 also might be presenting some antigens that may be cross-reacting with our joint antigens and leading to AS. So that might be the case. So that this HLA-B27 and this junction where the HLA-B27, the antigen, and the T cell meets is called the immune synapse, and that is where the most of our immune activity happens. So why do we think HLA-B27 is important? First of all, the prevalence of B27 in AS is around 85%, whereas HLA-B27 in general Canadian population is only 7%. So clearly, there is something about HLA-B27. If you introduce B27 to a rat that usually does not develop any disease, just the introduction of B27 itself leads to arthritis, as you can see here in that second figure. It can cause changes of psoriasis like nail changes, inflammation in the skin. You see the inflammation in the skin also in the tail here, psoriasis like changes. And in the gut also, compared to normal gut, you see that there is significant inflammation happening in the gut. So almost all the features of AS and associated conditions can be seen just by expression of HLA-B27 in the rat model. So that was for another strong indication that B27, it's not just a bystander, it may actually be causing disease. So how does B27 cause disease? So even after 50 years, we don't know exactly how, but there are a few theories, okay? So for the first hypothesis is that just like HLA-B27 presents hepatitis C and HIV antigens, it may be presenting some antigen that CD8 T cells in our immune system may be recognizing, and this antigen may be cross-reacting with another antigen in the SI joints or in the enthesial tissues or in the rest of the musculoskeletal system. Maybe it is cross-reacting with an antigen in the eyes causing iritis. So that may be one of the mechanisms and is called arthritogenic peptide hypothesis, because maybe this peptide is arthritogenic or can elicit arthritis or cause arthritis. The second mechanism is that B27 may actually not be participating in the immune system at all. B27 itself may be accumulating inside the cell and causing a lot of inflammation. And that is called the misfolding hypothesis, because B27 tends to accumulate and misfold. The third one is that B27 may be taking on abnormal shapes on the surface, and instead of our regular immune response, maybe other abnormal immune responses may be triggered, because B27 has this tendency to misfold and form abnormal structures. You can clearly see it looks different from the normal appearing B27 on the surface. So maybe it is taking a different shape and the immune system thinks this is abnormal and you get reactions. So there are a lot of experimental evidences supporting each of these hypotheses, but nothing really very strong so far pinpointing against one. But as I will show you in very recent developments over the last couple of years, there may be a greater emphasis on looking at the arthritogenic peptide hypothesis, and maybe there is an antigen that we are exposed to that is driving this disease. Could it be a viral infection that we experience? Could it be exposure to smoke? Could it be pollution? Could it be in the drinking water? Could it be a diarrheal illness that we had at some point during our life? So those things are yet to be worked out, but there is more and more evidence mounting, pointing towards perhaps an antigen-driven process in AS. So this is where we'll talk about the new discoveries. So if we go to understand the latest discovery, let's go back a few years where Dr. Inman actually studied the T cell receptor, or that immune cell receptor that recognizes HLA-B27. And normally, when you look at T cells in our immune system, if it has the opportunity to see multiple antigens, you will see a lot of different kinds of T cells. But if the immune system is driven by one or two antigens, for example, in AS, if the immune activation happens because of specific antigens, then you will tend to see more T cells that recognize that antigen. It's quite natural because they tend to proliferate and increase in number. So when you look at 100 T cells, instead of each of those 100 T cells recognizing 100 different antigens, you may say 10 or 15 recognizing only one antigen. So that shows that maybe that antigen is driving the immune response. So let's look at the T cell clones in B27 positive AS patients, B27 negative AS patients, B27 positive healthy controls, and just back pain controls without any B27. First of all, you can, and what you see in the y-axis is the number of patients, and on the x-axis is the total number of T cells that recognize specific antigens. Okay, so if you look at 8, 7, 6, that's quite a high number, and you see that being represented only in B27 positive AS patients. You don't see a high number of T cell clones in B27 positive healthy controls or B27 negative cases or back pain controls, showing that there seems to be a T cell driven by specific antigens in the B27 positive AS patient. So maybe there is T cell that is recognizing specific antigens. So fast forward to this study, which specifically looked at the arthritogenic peptide hypothesis, and I'll explain this better with this figure. So in this study, patients with ankylosing spondylitis and uveitis were included in the study. And in both uveitis and AS, both tissue and blood was taken. So for AS, peripheral blood, of course, and tissue is actually from the synovial fluid or the joint inflammation. It's very difficult to do a biopsy of the spine to get actual tissue from the back. So they took fluid from the peripheral joints because there was swelling. And for uveitis, obviously peripheral blood, and the tissue is eyes because it's uveitis or eye inflammation. So eye fluid was taken out. And what they did is they isolated the peripheral blood cells, the synovial fluid cells, and the eye cells out, and they did something called single cell sequencing, in which each individual cell was sequenced, and the type of T cell on each of these cells, or each of these patients was identified. All the different types of T cells was identified. And what they found was an expansion of this particular T cell called V beta 9 T cell with a particular motif, with a beta chain and an alpha chain. That is a specific T cell seemed to be expanded, just like we saw in the previous study done by Dr. Inman. But this team went to be more specific and identified a specific T cell that seems to be expanded. And you can see that that expansion is more in the tissues compared to blood. So yes, there you find some in circulation, but when it gets to the eyes, when it gets to the synovial fluid, they increase a lot, showing that they tend to home in on the joints in the eyes, uveitis, maybe in the gut causing colitis, maybe in the back causing sacroiliitis and spondylitis. So there is expansion of T cells. Perhaps it is driven by an antigen. They looked at what antigen could be driving this. They could not pinpoint exactly one or two, but there were clues that maybe there is a gut-derived antigen that is driving this. Okay, now why is this important? So remember that V beta 9, so that is the T cell that was very recently identified. So let's look at what that is. So you have so many T cells in our immune system, of which this particular V beta 9 T cells are only around 4% of all T cells. We all know that in cancer chemotherapy, what happens? We ablate our marrow. We get rid of all the immune system or the blood cells, and that's the reason why we are immunocompromised and you get infections, and that's the biggest cause of mortality and everything post bone marrow transplant and post chemotherapy and things like that. But imagine if you could only get rid of 4% of your T cells, remaining 96% is available for our immune system to be active. But that maybe the pathogenic T cells that are causing disease lies within the 4%. Then you have a very targeted immunotherapy that could get rid of only pathogenic T cells, and that's very, very, very promising if that is indeed the case. Okay, so that's why there is so much enthusiasm around this. So here is an example of a patient. So their company developed an antibody that actually binds to that specific T cell. Okay. So it was tried on this patient way back in 1983. The first symptoms started in this patient. By 3 years, 1986, the first diagnosis was established. B27 testing was done in this patient in 99, so quite a bit late. Probably they were on anti-inflammatory agents, as you can see here, starting at low dose and then increasing to high doses of anti-inflammatories. By 2004, anti-TNF therapy became available in that location, and the patient got access to anti-TNF therapy. Patient was on anti-TNF therapy for almost 5 years, failed therapy, went on to receive stem cell transplantation. After that, perhaps he was able to access somebody who thought stem cells could cure the disease. Unfortunately, it did not. Fast forward to 2016, hip disease was really troublesome. He got a hip joint arthroplasty, and then fast forward another 3 years, and then this anti-TRV beta 9 monoclonal antibody became available in his location, and he became a subject. So in 2019, he received the antibody first and with increasing doses subsequently up to 2023 when the publication was done. For the 4 years, the patient received this antibody against the T cell. Okay, this is what happened. Okay, let's start. We'll start seeing, looking from the time the patient got the antibody, and this is AxSpA, so high disease activity with the antibody. This is 2000. Where is it? 2000 and yeah, somewhere here. You can see that the inflammation disease activity is dropping. What you see here is the spinal mobility. You can see the spinal mobility has improved. What you see below this again is neck rotation that is significantly improving on treatment. So you can see overall there is a decrease in inflammation, improvement in spinal mobility, neck rotation, and all disease activity measures seem to be improving and sustained over 4 years. So very promising. This has gone on to a phase 2 study, which also was positive, but it's very early days, something to look forward to in the future. Okay, so that's about B27 T cells and the most recent advance in the T cell targeting field. Dr. Inman might be talking a little bit more on that during his treatment talk. Let's go back to our B27. And I mentioned that B27 is present in 85 to 90% of AS patients. However, if you take 100 individuals with HLA-B27, this happens very frequently in our clinic, right? Patients come in saying, hey, doc, I've got an HLA-B27 positive test. When should I start treatment? All right. So out of 100 people with HLA-B27, only 2 actually have AS. 98% of individuals with B27 walk out of that room without a diagnosis of AS. That is because B27 is so non-specific. And as I mentioned, 7% of Canadian population has B27, but disease is present in less than 1% actual AS. Okay, so it is a normal gene. So what causes AS in those 2% of patients? What drives those TRV beta 9 cells? What is the driving cause of that? So there was really no clue till the advance in genome sequencing. So genome-wide association studies were done because the whole genome mapping was done, polymorphisms were identified, and we could study in large numbers these polymorphisms within the genes in AS patients and controls, and multiple genes got picked up beyond HLA-B27. Of course, B27 is the strongest, but there were many others that are close by there. And ERAP1 was of particular interest to us. You can see the table here of multiple other genes that got picked up. But the interesting thing is, you look at this number, that's the odds of developing disease if that gene is present. And for HLA-B27 is very high, 90. But once you leave B27 and go down the list, all the others have very, very, very small contributions. And together, they may be playing a role, but nothing close to HLA-B27. So we still haven't, I don't think we still have cracked the code of that unique combination of 3 or 4 genes that come together with B27 and cause disease. But ERAP is very special, and we had a very close interest in ERAP because it is closely linked to the hypothesis that we mentioned earlier about how B27 might be causing disease. Okay, so let's go to our antigen presenting cell, and let's say this is the antigen that comes out of that virus. Okay, so that is broken down within our cell by a molecule called proteasome. It breaks it down into antigens. It enters an organelle in the cell called ER, or endoplasmic reticulum, where ERAP trims it down into an appropriate length, and that when it's perfectly fitting on HLA-B27, it goes to the surface and you get a normal immune response. Now, if ERAP is abnormal, instead of a perfect fit of B27 and the peptide there, you may have abnormally long peptides sitting there because ERAP is abnormal. Now you on the surface, you have the B27 presenting abnormally long peptides, Or we already talked about B27 misfolding. That misfolding can increase and cause a lot of stress and cytokine release, or you have abnormal surface expression of these cells leading to abnormal immune responses. So you can see why there is a lot of interest in ERAP, because we have been trying to find out which of those hypotheses of B27 is actually playing a role. Now you have another gene in the same pathway that could explain. There was a lot of study around that. Straight away, we'll go to ERAP1 knockout studies, because that is very interesting. What was identified in the polymorphism association in ERAP is that if you have ERAP1 activity was higher in patients compared to controls. So the idea was, if ERAP1 is higher and is closely linked to B27, can you reduce ERAP1 activity and reverse disease? So that idea was used in the animal model, where in the B27 animal model, where these are animals, B27 positive rats with ERAP, and these are rats without ERAP, and this one is where one gene is knocked out, both are not knocked out. And you can see that the arthritis has improved, which is what you see here. Compared to the diseased rats, the arthritis has improved when you knock out ERAP. So it seems to be interesting. However, look here, what happens to the colitis? When you knock out ERAP, the colitis seems to be worsening. So this brought the idea that, okay, AS patients can have psoriasis, uveitis, IBD, and Crohn's colitis, arthritis of the back, arthritis in the peripheral joints. Maybe, the different tissues are getting inflammation because of different mechanisms. So to really control it, we really need to understand what is a predominant immune process within a patient. And really, we need to be doing personalized medicine, understanding exactly for each patient what is the best treatment. That may be the reason why when we try and treat blanket for same drug for every patient, you only get 50 to 60% response, because 40% are not responding. That was not the best treatment for them. Okay. So finally, we'll put everything together. We have the ERAP B27 story, antigen B27 unfolded protein response, and then this B27 comes to the surface. You get the CD8 T cells, and you get an immune response. So where does this antigen come from? There is a big hypothesis that probably it is coming from the gut. Maybe it's in our diet. There are a lot of patients who believe that a low starch diet and a low carbohydrate diet is good for them, and they feel that when they go in and have a pizza one day or some bread one day, they tend to feel that inflammation and their joints feel warmer. So it might be working for them. So is it linked to the microbiome? In fact, if you look at patients' bowels, there are changes in the microbial organization. There is microbial dysbiosis, or change in the structure, microbial colonies in AS patients compared to healthy controls. If you look at patients in different cohorts in different countries, oftentimes you see the dysbiosis, but it's not caused by the same organism in the different countries. Obviously, because the diet is different, the environmental situation is different, and that's why we have not yet been able to pinpoint. But there seems to be a difference there in the gut, and as a result, our Paneth cells or sentinel cells within the gut that recognizes these produce a lot of cytokines, interleukin 23, that further expands immune cells. These immune cells can be seen in the blood circulation. Perhaps they're coming from the gut into the circulation, and then they go into the joints and cause inflammation within the joints, so getting arthritis. Okay, so maybe there is a gut origin of everything, ultimately ending up in the joints, causing inflammation. I think this is probably the last part on the immunopathogenesis side, where I wanted to show you one patent pending discovery that we made in our lab here. So this is a discovery on a molecule called macrophage migration inhibitory factor, and a big team has really worked behind this discovery, and we're now working with a company trying to take it to clinical trials and bring it to help patients with AS. What we found was that this MIF can drive inflammation. it can drive bone proliferation. Two cardinal features of ankylosing spondylitis. And most of the molecules that you have known so far, like TNF and IL-17 and everything, are known to drive inflammation. Quite often, especially if you look at rheumatoid arthritis, instead of bone formation, it actually drives bone loss and erosion. So MIF, on the other hand, could drive bone formation, which is actually the cause of spinal fusion. So we got very interested, maybe MIF has a key role. So we went ahead and knocked it down in an animal model, showed that the disease could be reversed. We used an inhibitor against MIF and showed that the disease could be reversed. We worked on finding out the different interactors and drilled down on the mechanism by which MIF is driving inflammation and bone proliferation. So 3 big papers came out of this work. I won't be going into the details, but I'll just show you this, that with the help of our collaborators in Korea, we actually looked at the spinal tissue of AS patients and compared it to osteoarthritis. And what you see is very high levels of MIF expressed in the spinal tissues of AS patients compared to nothing in controls, showing that MIF is also present in the actual place where there is a lot of inflammation causing pain and bone formation. So still early days, but a lot of progress in this field as well. So to summarize the pathogenesis side of things, I've not covered everything in the interest of time. Just talked about the familial concordance of disease, the twin studies, the family studies, the role of HLA-B27, the non-B27 genes that have been discovered, which all have small contributions, but together they may be massive. And the latest discovery of the T cells, that the V beta 9 T cells, which forms 4% only of the T cells that we have, which may be driving disease, a potential target for treatment. We talked about the gut origin of potential T cells and immune cells being driven by microbial changes maybe. And finally, we talked just very briefly about the latest discovery of MIF driving inflammation and bone proliferation. Very quickly, I want to take you through the clinical, just set the stage for Dr. Inman to talk about treatment. I'll just very, very briefly and quickly go through some of the slides on how patients present with spondyloarthritis. So inflammatory back pain clearly is the most important presentation. But along with that, you may see structural changes when X-rays are done. If it is of sufficient duration, changes within the sacroiliac joints may be seen on X-rays. But sometimes, it may be very early. Changes have not already happened in the SI joints and X-rays, or all patients don't develop structural changes. It's predominantly an inflammatory disease without much structural changes. In both situations, you need to do an MRI to look for inflammation. And what you see here bright is actual inflammation in the sacroiliac joints. And that is sacroiliitis, which can, in the correct context, and can be diagnostic for AS. Here you see inflammation in the peripheral joints. Peripheral joint inflammation can lead to bone spurs, plantar fascia spurs, and heel spurs can happen. Peripheral joint involvement is usually seen in around 30-40% of patients, not in all AS patients. Bowel inflammation is seen in around 10%. Psoriasis is seen in around 10%. Eye inflammation is seen in around 30% of patients. So uveitis, Crohn's colitis, and psoriasis are strong associations. But the dreaded long-term complication for most people is the spinal fusion, leading on to bamboo spine and stooped posture. Okay. Long-term complications are not just restricted to the spine. There is increased vascular mortality. And vascular mortality, if you look specifically, there is a 36% increased risk of death, 60% increased risk of death from strokes, 35% increased risk from heart attacks. And these are relative risks. And it came from a study done in around 25,000 AS patients in Ontario compared to 100,000 controls. So you need a very, very large population study to show this, because the actual risk is very low. You have to compare the risk of having a heart attack and death from that in a 30-year-old with AS to a control with AS. So very, 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 very low risk of having a heart attack at 30 years or 40 years of age. But you can imagine having AS for 20 years, 30 years, or 40 years. By the time the patient is 60 or 65, they would have accumulated more damage in the coronary arteries than a control or non-AS patient would have. So if we treat patients at the very early stage from 35 or 40 years of age, by the time they're 60, their coronaries and heart should be as healthy as anybody else. So that's the importance of studies like this. Okay. In PS, those who have PSA may also have some nail changes, skin changes, especially peripheral joint involvement and dactylitis-like changes. So when there is association of AS with psoriasis, these changes also can be seen. Okay, this used to be the situation. This graph actually shows, the first graph here shows the age of onset of symptoms. This is the age of diagnosis in males. This is the age of diagnosis in females. You can see a 10-year gap in diagnosis in males and almost 20 years before diagnosis made in females, because the concept before was that females don't develop AS. If there is back pain, it's likely just pain syndrome or fibromyalgia, not AS. Now we know that males and females almost have equal prevalence of AS. So the clinical level of suspicion is much different these days, and the gap has decreased, but still not perfect. Okay, how do we try and reduce the gap? Understanding all the things that we mentioned about the inflammation elsewhere, the peripheral arthritis, the use of MRIs, use of blood work to look for ESR, CRP, doing the test where appropriate for B27, making sure that we don't miss Crohn's, colitis, and psoriasis. And these are the early ways to do it. I think we'll skip that. And also distinguishing the type of back pain may also be important. And this is, I think, an important message to take home. All back pains are not same. It is not a good, perfect tool, but at least it's a start. Back pain that starts in somebody who's 70 years of age is different from 35-year-old with chronic back pain. Back pain that lasts for 1 week is different from like 3 months or 4 months of back pain, right? And back pain that starts after going to the gym is different from insidious onset of back pain that you can't really pinpoint when did that pain start, as opposed to I was lifting a bag off from when I was getting off a plane. So that's instead of acute onset. Back pain that is associated more with exercise is different from back pain when you're at rest, and especially in the morning, a lot of stiffness is seen in spondyloarthritis. So summarizing, young age of onset, chronic back pain, which is insidious in onset, associated with stiffness and improving with exercise, is more a feature of AS like back pain. Okay. Imaging is great, but unfortunately it is not really perfect. And the image here I put is because our pelvis is actually tilted down and forward. It is not perfectly anteroposterior. So when we do x-rays, it's very difficult to see the SI joints. This is a CT scan image, and you can see if you do CT scans, you can see the SI joints well. But CT scans have a lot of radiation. So it's not and also there is a wait time in getting CT scans. So it's not a good tool to just blanket use in everybody, unnecessary exposure to that much radiation. So we have to perfect it. And this is just to show you, this is more or less a normal SI joint. And you can see on this side, there is erosion and partial fusion happening. I'll click through this. And this is an MRI showing changes of inflammation there. Changes of erosions and damage happening there, and some ankylosis happening there. So there's a lot of advance in the way we read MRIs, the techniques used for MRIs, and also our ability to identify small changes in X-rays as well. So imaging advances, increased awareness in clinical case detection, all of these have hopefully led to significant improvement in diagnosis. Finally, I'll leave you with the concept of axial spondyloarthritis. We always talk about AS, and ankylosing spondylitis. But now axial spondyloarthritis is a term used. So let this be the last slide where I'll leave you with this concept. So axial spondyloarthritis refers to the full spectrum of AS. Okay. And let's start even before that spectrum starts. So somebody is born with HLA-B27, so they have a genetic predisposition. At some point in their life, they are exposed to something that triggers back pain. Okay, so that at that very early stage, if you do x-rays are negative. So patients technically don't have ankylosing spondylitis because AS or ankylosing spondylitis is defined by x-ray changes. But because it's an inflammatory process, if you do MRI, sacroiliitis is detected. So this would be a non-radiographic axial spondyloarthritis. After a few years, the X-rays become abnormal and it becomes a radiographic axial spondyloarthritis or AS. And after a few years, spine also can get fused and you can get advanced AS. So sort of genetic predisposition, early non-radiographic axial SPA, radiographic axial SPA, advanced spinal fusion axial SPA. So that's sort of the natural course of disease. But fortunately, the majority of individuals either stay here without developing disease or they may have only sacroiliitis and MRI. A very small proportion actually becomes AS, and even smaller proportion actually goes on to fusion of the spine. So this is not the outcome in the vast majority of individuals, fortunately, even without treatment. And with treatment, there has been a huge amount of improvement, and the prognosis of patients with AS has significantly changed over the years. So I think I'll stop there in the interest of time.
Thank you, Dr. Haroon, for sharing all of that information and the great insights and knowledge and expertise. And I know that we do have time for a few questions here before we take a short 10-minute break. We'll take a 10-minute break just after 8 o'clock. But there are some questions here, and I'm just going to, I see Rob's, Dr. Inman's slides are up. We're just going to pause on that for a moment. So one question here is, and you talked about the gut a little bit, so these questions are associated with that.
Sure.
Is there any association between AxSpA and colitis?
Yeah, so 2 or 3 different ways to look at it. First of all, the clinical association between AxSpA and colitis. If it is ulcerative colitis specifically or Crohn's colitis, yes. So the numbers we talk about are, if you do just endoscopy and you do biopsies in the gut in 100 individuals with AS, 60 to 70 of those individuals may show a little bit of inflammation, okay? So there seems to be a very strong connection as regards to inflammation and AS. However, the vast majority of them don't have overt colitis, like they don't have recurrent diarrhea, they don't have blood in stools, they don't have loss weight. And if this biopsy was not done, this would never have been detected in their entire life. So there's something there that is driving it. Now, out of those 100 AS patients, 10 may have overt colitis with diarrhea and all, and that leads to a diagnosis of Crohn's or ulcerative colitis that leads to treatment. And the good thing is that the treatment for AS is most often effective for the treatment of Crohn's colitis as well. So that is on the clinical concordance, just prevalence wise. However, there is also another thing that needs to be kept in mind. I mentioned 30 to 40% of AS patients have peripheral arthritis as well, right? And the disease activity in the bowel is strongly correlated with peripheral joint arthritis, not so much the back pain. So you can have a flare in the bowels with a lot of inflammation, but the back is doing well. But there is a higher likelihood where the knee or the ankle can swell up at the same time, as opposed to the knees, ankles, and the bowel may be quiet, but the back can flare. So there doesn't seem to be an association between the gut and the back, but there is a strong association in the disease activity between the bowel and the peripheral joint. So that's the other interesting observation.
And then there's another question here, and it's almost the same question. Just what's some of the latest research on treatment that can control spondyloarthritis and Crohn's?
Yeah, so I'm pretty sure Dr. Inman will cover this in great detail. So I would hold it for that.
Okay, so we'll hold it for that. There is a question here. I'm just trying to get them related here. So, has there been any research on how diet and eliminating inflammatory foods can positively affect the condition?
Yeah, so to answer the question, straightforward, easy answer is no, there is no strong proof, and it's very difficult to prove, all right? First of all, maintaining a constant diet for a sufficient period of time and then controlling that with another form of diet. These are all very, very difficult studies to do, so there is no direct proof. But if you go back many, many years before all these treatments were available, if you take simple treatments that were available to patients with rheumatoid arthritis and other inflammatory diseases, they would be admitted in the ICU, given only IV fluids, and give extreme caloric depletion, and then naturally the adipocytes come down, the adipocyte-related cytokines come down, called adipokines come down, the inflammation comes down, and the patients get discharged. So there is definitely something with the caloric restriction. Is that caloric restriction primarily because of carbohydrate restriction and all? Anecdotally, patients report that, but I don't think scientifically it's been proven.
Great, thank you for that. Another question here is HLA-B27 connected to genetic history from one region or country?
Very, very good question. So the association of B27 with AS and the strength of association varies with the place where this testing is done. B27, if you look at the map of B27, it is actually a mirror image of let's say malaria, for example. Or so there might be a survival advantage of B27 against some infections, or the reverse, maybe during the migration of individuals from, let's say, the Caucasus Mountains across, and they came over to Haida Gwaii and then down there, it's possible that during that migration, those who were B27 positive survived, and the B27 negative individuals were succumbed to some form of infection, right? So if you go up northern BC and look at some of those populations, every other person can be B27 positive because of very high prevalence of B27. It doesn't mean every other person has AS. So having B27 in that population is not a very high risk because there's 50% chance you could have AS. But if you go to Japan, the prevalence of AS as opposed to 7% in Canada, prevalence of B27, 7% in Canada. In Japan, it's only 1%. So having B27 there is a much higher risk because the denominator of B27 in population is very low. So clearly it is important in diagnosis, but the chance of finding B27 positivity in AS is much higher in Canada than in Japan, for example. Yeah.
That's interesting. I wonder if we can try to squeeze in a couple more before we take a short break before Dr. Inman comes on. Can pollution or environmental matters cause AxSpA?
Again, no definitive proof. So environmental influences are the strongest one in connection with arthritis has been shown mainly with rheumatoid arthritis, and there is sort of a scientific path that has been shown, and that is related to smoking. And for example, in rheumatoid arthritis, if there is smoking in a genetically susceptible individual, an enzyme can be triggered. The enzyme leads to antigenic change, leading to rheumatoid arthritis. That kind of a gene-environment interaction specifically has not been shown so far in AS, but maybe the latest study that I showed about T cell proliferation, that is very specific, that seems to be driven by an antigen. If you are able to find out what that environmental exposure is, perhaps we could identify what needs to be avoided. Yeah.
Thank you for that. I see one of our directors of the board, Anthony Florendo, has asked a question. I think that you've already covered it, but is there an AS-friendly diet?
Oh, yeah. So wish we could do that study and show that. But in general, if you at least from what our patients say is that exercise and low caloric diet restriction and a healthy diet with lots of fruits and vegetables should be good. But at least some of the patients feel that if they have a lot of starch, it doesn't seem to be helpful, but not proven, obviously. Yeah.
Okay, great. So we're just going to pause there. I see that there are many other questions. We're going to try to, like I said, we're going to have a 30-minute open Q&A segment following Dr. Inman's presentation. So we are going to take a 50-minute break so everyone can stretch. Why don't we come back here around 8:12? So 8:12 Eastern time, and we will queue up Dr. Inman. Thank you so much, Dr. Haroon.
Thanks very much, Brenda, for the invitation to present at this forum. So as Dr. Haroon outlined, we're learning more about the basic science of spondylitis and learning more about early diagnosis, which is a big issue. So I thought in the remaining section, we'll talk about how this could actually translate into improved treatments. So as Nigil mentioned, when rheumatologists think about spondylitis, we think of it as a center sphere of a lot of overlapping types of arthritis. So for example, about 10% of our patients have psoriasis. So this would overlap with that circle up to the right there. So ankylosing spondylitis plus psoriasis or psoriatic arthritis. We, at the left, down at 7 o'clock, we have arthritis associated with ulcerative colitis and Crohn's disease. That's about 12% of our patients. And then anterior uveitis, which is also called iritis, occurs in about 35% of our patients. Just in passing, some of these other subsets are interesting. So juvenile spondyloarthritis. So about 20% of our patients at Toronto Western have the onset of their spondylitis in their teenage years, their childhood, their grade school or high school years. And then when they turn 16, they move over from Sick Children's Hospital over to Toronto Western Hospital, and we follow them along. So it's a very interesting group because the kids start off and sometimes they have rather mild disease and sometimes it's more severe. So when we think about the focus today is obviously on spondylitis, but it has a lot of overlap with inflammation in the skin, that would be psoriasis, in the eye, that would be iritis or uveitis, and then gastrointestinal tract, that would be inflammatory bowel disease. So Nigil mentioned this in passing. The diagnosis of ankylosing spondylitis starts with chronic back pain. We really can't make a diagnosis, and if somebody, even if they've got B27 or something, they've got to have significant and persistent back pain to start the discussion. And obviously, that's usually what takes our patients to their family doctor or to the rheumatologist is back pain. But the interesting thing is as Nigil mentioned, the X-ray is really an important part of the diagnosis, much more so than say in rheumatoid arthritis. And it really requires some X-ray changes in the sacroiliac joint. Now that, in a sense, imposes sort of a delay in diagnosis, because if we have to wait to see some changes in the X-ray on the sacroiliac joint, that means there's kind of almost an imposed delay in the diagnosis, and which is a real challenge for us to try to make this diagnosis earlier. So the delay in diagnosis is a significant issue for us. So this is a study we did with the Spondylitis Association of America. And we asked the patients, so how long was it between the onset of your back pain and the diagnosis? And you can see that like this is not an encouraging chart. This is a few years old, but it's still a challenge for us. You can see that if you draw a line right through the horizontal part of that pie, then almost 50% of patients have at least 6 years of symptoms before the diagnosis is made. And that's really an indictment of the system, I would say the healthcare system in a sense. Like, how do we actually more effectively diagnose our patients earlier? And we are doing better. There's some interesting strategies about that. But this is a significant challenge for our patients. And of course, and many on the call may relate to this, that in that window where you have undiagnosed back pain, you might be referred to many different practitioners, chiropractors, physiotherapists, acupuncturists, and it might be a long time before the diagnosis is actually made. So this is something we're working with the CSA very closely on, and how to actually move this agenda forward. I think one of the totally shared goals between the CSA leadership and the rheumatologists and the patients is to somehow make a shorten the interval between the onset of back pain and the diagnosis, because we know we can do better than we have in the past. So this is a slide. Laura Pasland, who's actually unfortunately not with us, has played a really important leadership role in contributing to how we could adjust the model of care for earlier diagnosis. That's the real challenge we want to overcome, is making a diagnosis earlier. So at the moment, since the X-ray is anchored in an X-ray or an MRI, we really want to see the patients at an earlier time, and the physiotherapy screening model that Laura has played an important role in is contributing to a shortened time to diagnosis. That's the goal, that we want to eliminate the delay in diagnosis. So the X-rays, which is the modified New York criteria, takes a while to develop. If we wait for that X-ray to occur, we're losing a lot of time. Now, you can see that if at a time when the X-rays are still normal of the pelvis or the sacroiliac joint, the MRI can be very positive. So as Dr. Haroon mentioned, this has broadened the concept of ankylosing spondylitis, which essentially required X-ray changes, to now include what we would call MRI positive AS. It's now, technically it's called non-radiographic axial spondylitis. It's not a good term, but the old approach to diagnosing AS was an X-ray. We still use that, but now we use an MRI much more extensively to identify the patients earlier. So these are just X-ray changes. But by convention, you have to have like a grade 3 or grade 4 change in the sacroiliac joint. Next slide. And we're trying to get around that. So you can see here that, next slide, if there's minimal change, here's the progression that we are trying to interrupt. So what starts as a positive MRI on the left part of the screen at a time when the X-rays are negative, then it progresses over to X-ray positive sacroiliitis or sacroiliac joint M, and finally it involves the spine. So our goal is to interrupt this trajectory. Like, how can we, you can see back in the lower left corner there, sometimes the patient may be B27 positive, have back pain, but both the X-ray and the MRI are negative. So that's probably very early in the course. Then the MRI becomes positive. Then the X-ray becomes positive. And so the challenge for the rheumatology community and the family doctors working together is to interrupt this trajectory. How do we stop this progression? So the SPARCC managing guidelines, this has just been updated. Sherry Rohaker from the Western Ontario, University of Western Ontario, now called Western, has brought together a whole team of spondylitis experts. And we just published an update just very recently on the management guidelines. So this is kind of the principal outline. So when we think about the treatment of ankylosing spondylitis, it is very much anchored on the left side of the slide in education, exercise, physiotherapy, and patient associations and support health groups. And I would highlight the Canadian Spondyloarthritis Association. And Brenda is doing a terrific job in leading this charge, making a difference. Why do we think the patient associations and the self-help groups are really important? Is that education plays a really key role in this management of this disease, because we not infrequently will get a young person coming in. They might have had a B27 positive test by the family doctor. And if you Google ankylosing spondylitis, it can be a little intimidating, right? You see an X-ray of a progressive fusion of the spine. And if you're a 25-year-old patient with low back pain, it's kind of can be quite intimidating. So we spend a lot of time thinking together with our patients about the variability in the course, what actually can modify the progression of the course, what is the most safest and most effective way of managing the symptoms. So you see under education, we've got exercise. We'll make some comments. Laura Pasland's one of the real experts in this field. So she's got good evidence that exercise actually, besides maintaining your flexibility in your spine, which is one of our key goals, exercise itself actually has an anti-inflammatory effect. So you can actually measure some of these molecules that drive inflammation, like TNF, tumor necrosis factor, like IL-6. If you measure them before and after rigorous exercise, they seem to improve. So exercise itself has a very interesting anti-inflammatory effect. And of course, it's good for your cardiovascular disease, et cetera, et cetera. Physiotherapy plays a really important role here. Laura Pasland's got a training program called the ACPAC program. And we are training a group of physiotherapists across the province. And our goal is to be across Canada, where these expert trained physiotherapists understand ankylosing spondylitis or axial SPA, and they know the kind of exercises that should be undertaken. Core strengthening, active exercises, not passive exercises. And so this left column here, education, exercise, physiotherapy, the CSA and associations are really important, and we're really very grateful to partner with the Canadian Spondyloarthritis Association because we really share the common goal of improving outcomes. The next bar across the top there is NSAIDs. So those are non-steroidal anti-inflammatory drugs. So this would include drugs that you'd be familiar with, like ibuprofen, Motrin, Advil, Aleve, or naproxen, diclofenac, and indomethacin. I would say the commonest of those is in our practice would be probably ibuprofen, Celebrex, and naproxen. Some can be bought at low dose without a prescription. You can get Aleve over the counter without a prescription. The reason that NSAIDs, non-steroidal anti-inflammatory drugs, are considered the cornerstone of pharmacological management is many times they make a significant difference in the symptoms. So we have a substantial number of patients, not maybe 20, 25% of our patients, that actually do well with these two axes. If they're doing their exercise, their physiotherapy, and their NSAIDs are taken on a regular basis, they actually do fine. By fine, I mean they have an acceptable level of symptoms, they maintain their functional status, their quality of life is good. But this is where it all begins. Before we even think about escalating treatment, we want to make sure that the exercise physiotherapy program and the adequate trial of NSAIDs are the cornerstone. One of the questions that comes up is whether or not NSAIDs have to be taken on a regular basis, or can you just take them when you think that you need them, right? So the question here was posed by our colleagues in Germany several years ago, whether if anti-inflammatories have any disease modifying effect, right? So the question is it just symptomatic, or is that actually improving the course of the disease? And on the next slide, this is what's called a cumulative probability plot. But what their authors here did was, so the people, there are two groups here, they're kind of hard to see. One is light green, one is dark blue. The continuous ones were taking anti-inflammatories that happened to be diclofenac or Voltaren. They took it on a regular basis, twice a day, religiously. They took it twice a day, regardless of how they felt. And then the other group just took it when they needed it. And the conclusion of this study was it didn't seem to differentiate X-ray progression. The vertical axis here is the progression of spinal fusion on the vertical axis. So after 2 years, the two groups that just took it when they felt they needed it, and those that took it on demand, on schedule, there was no difference. So the conclusion at the moment is that anti-inflammatories alone, like diclofenac, Motrin, Celebrex, are useful for symptomatic control, but they don't modify the progression of the disease. So when patients are asking us, do I have to take my naproxen or my Motrin every day? We usually say, no, you can take it as you need it. If you're out hiking on the weekend or playing a game of golf or tennis and your back pain's up, more active, by all means take it when your disease is more active. When you are past the flare, you can drop off the NSAIDs. So because over time we become much more aware that the NSAIDs themselves carry some risks. So we're using it as cautiously and judiciously as possible. So as I said, there are some patients with axial spondyloarthritis. I'll call it AS because it covers the old term ankylosing spondylitis and the new term axial SPA. So we'll call it AS. So we start with the axial disease as the back pain. Now, some of our patients have, maybe 25% of our patients have arthritis in other joints besides the spine. That might be the heels. They might get tendonitis in the heel or the heel spurs. They might have inflammation in their wrists or their knees, and which is what we call peripheral disease, like the outside of the spine. Sometimes those patients get treated with methotrexate or here sulfasalazine. Those are drugs that are used for rheumatoid arthritis and psoriatic arthritis, but although they can be useful if you're experiencing a lot of hand, foot, hip, knee pain, if it's primarily spinal disease, or what we're calling axial disease here, it's been found rather disappointingly that those drugs like sulfasalazine and methotrexate actually don't work on the spinal arthritis. So this has kind of simplified the approach, because we start with an adequate control of NSAIDs. And what that usually means is at least 2 weeks of 2 different NSAIDs. So you'd be taking naproxen twice a day for 2 weeks, and then a trial, say, of Celebrex or ibuprofen for 2 weeks. And if that's not controlling the spinal or the axial disease, the next stop is biologic treatment, right? So that is this decision, when you go from NSAIDs alone up to the addition, when you step up, or what we call escalate, when we escalate the treatment from nonsteroidals to biologics, it's a very important juncture in the management strategy, right? And the question is, when is it time to escalate to a biologic? So let me just make a couple of comments on that escalation. I would say the dominant factor when the rheumatologists and the patient come to a decision that the nonsteroidals are not getting the job done and we need to escalate is primarily anchored in symptoms, right? So that's the dominant factor. When the back pain and the associated fatigue and stiffness is not well controlled, it's impacting the patient's quality of life, their activity, their enjoyment of sports and recreation. When the back pain is still a significant patient problem, then that's grounds enough to have a serious discussion about escalating out to a biologic, right? So that's the other thing in passing I would say is that sometimes the NSAIDs alone can carry problems. So, for example, patients with underlying inflammation in the bowel, inflammatory bowel disease, really can't tolerate NSAIDs. So we may say, well, I'm obliged to give you a trial of NSAIDs before the biologic, but if there are some patients that simply can't tolerate NSAIDs, and patients, say, with Crohn's disease would be one example. In that case, to achieve satisfactory control, we might go even more, escalate more quickly to the biologics. But it's a shared decision between the clinician and the patient about what the appropriate time to escalate to a biologic is. Okay, so that's important. Well, I'm sure we'll have some questions on that. So the first class of biologic agents that came out, these are almost 20 years ago now, started with infliximab and etanercept, are called anti-TNF agents. They all block the same molecule, but there's some interesting differences. For example, infliximab is given intravenously. The other 4 are given by self-injection subcutaneously. 4 of them are monoclonal antibodies, except for etanercept, that's called an Fc fusion receptor molecule. And these have proved over the 15 years we've used them to be very effective. In fact, if you compare, just a comment, I'm going to show you a couple results on different trials, so you just have a sense of how the rheumatologists come to conclusions about effectiveness. So, not to get into the details here, but when a new drug comes down the market, the new biologics come in. We want to try this biologic agent in a group of patients with spondylitis to see whether it really works. So we have to have some agreed upon measurements. And the minimal in most of these trials would be a 20% improvement in the back pain, but it's not just the back pain. It's the patient global assessment, like how are you feeling today? The pain assessment, like how bad on a 10-point scale is your pain? How are you functioning? Like how is the new drug affecting your functioning? And then how much early morning stiffness you've got. So many of you, I'm sure, have completed a BASDI form in your rheumatologist's office. We use that a lot. So you can see that these are kind of incorporated in the BASDI. So these aren't the total picture, but they're agreed upon measurement outcomes. That whether you're getting treated in Toronto or St. John's or Vancouver, the rheumatologist will generally use an agreed upon scale like this. Okay, we're generally looking at least a 20% improvement in your symptoms. Now, using these kind of scales, you can, this is actually a 40% improvement. It's a little higher bar. This compares the 5 TNF agents, and you can see that these, first off, these are not head-to-head comparisons. They're just taking different studies that were published in randomized controlled studies in AS patients and comparing them. And you can pretty much see, even from the back of the room, that it looks pretty comparable. like when you compare infliximab, etanercept, adalimumab, golimumab, and certolizumab, they all pretty much look comparable. So that's an important consensus. And I think that most rheumatologists now subscribe to the fact that these are pretty equally effective. I would say some of these names might or might not be familiar to you. So infliximab was called Remicade at the beginning. We now have biosimilars like that we use. Inflector is one example. Etanercept was always Enbrel. Now it's Rensis and Erelzi. Adalimumab, which is always at the beginning was Humira, actually has quite a variety, Adaccio, Hyrimoz, etc. So what's happened in the last 3 or 4 years is the originator, in other words, kind of the brand name drug, went off patent, and now the biosimilars, or essentially generics, are now available. The advantage of this is that it's a vastly less expensive exercise. So whether the payers are your private insurance company or it's the provincial drug authority, like the Ontario Drug Benefit Plan, this has actually reduced the cost of the biologics significantly, this move on. And there might be some questions on this, but I think there's a strong consensus that the biosimilars are equally effective and equally safe as the original drugs. So this just shows that this compares the magnitude of the difference. This happens to compare adalimumab, certolizumab, some of the anti-TNFs, and they really look in patients with non-radiographic. This is remember the MRI form of the disease is similarly responsive. So TNF agent blockers work in both the X-ray positive and the MRI positive form of the disease. And this reinforces that this comes from a biologic registry in the UK, and it didn't really matter like whether the rheumatologists had called this non-radiographic the MRI form or the X-ray form. Both groups were comparably responsive to biologics. So as time has passed, there's less, I would say, less attention paid to this discrimination. Sometimes it's important to get adequate coverage for your biologic. When we file with your insurance company, we have to justify why we're certain of the diagnosis and whether it's anchored in the X-ray or the MRI. So that's still part of the discussion, but it looks like regardless of the different subtypes of axial SPA, they're equally effective, responsive to biologics. So clearly the symptoms are improving, right? So the pain is the most dramatic change. And if you've had a good response to biologics, you probably, many people on the call may know this. We saw a patient today in clinic who had like 5 years of back pain, and after first injection of a TNF monoclonal antibody, she knew something had changed dramatically. So, and there's some improvement in quality of life and flexibility. The question was whether or not it's just a very effective analgesic, or does it actually change the course of the disease? This is actually a very nice study that was led by Dr. Haroon several years ago. It involved 4 centers in the United States, as well as the center at Toronto Western Hospital. And that was the first study that showed that the TNF inhibitors actually reduced the progression to spinal fusion. So this is really an important paper, because originally it was debated whether the biologics actually modify what we call radiographic progression, which would be the tendency to spinal fusion. And you can see here, by the way, that the earlier you start on the drug, the greater the magnitude of impact on X-ray progression. All right, so this is another reason that I think SPARCC, CSA, the rheumatology community, and the patients are all kind of adopting a common strategy to diagnose and treat earlier, because earlier diagnosis and earlier treatment, particularly with a biologic, has better long-term outcomes. Okay, so when we're discussing a biologic, we talk about short-term goals, which is improvement in pain and stiffness and fatigue. We talk about long-term goals, about modifying or delaying the progression of spinal fusion. So this was great. The smoking, we found it in the study, the smoking is bad too. A study we've actually just published by Evelyn Gendron from Laval, she's back in Quebec City, has also found that alcohol has a tendency to accelerate progression too. So there's not to take all the fun out of your social activities, but it looks like there's some evidence that smoking and drinking might be negative predictors of outcomes. So those are all TNF inhibitors. They've kind of dominated the scene for a long time. And then several years ago, a new blocker came out called an IL-17 blocker. So, these molecules, TNF and IL-17, are small molecules that drive inflammation. So secukinumab is a monoclonal antibody, just like infliximab is a monoclonal antibody, but the target is against this what it's called the cytokine IL-17. And the good news for us here was that if you look on the left, if patients were naive, they've never had a biologic, the response rates were really quite comparable to the TNF inhibitors. So the IL-17 inhibitors like ixekizumab and secukinumab really were response. What was particularly heartening for the patients and the doctors was the group on the right. So these are patients with what we call TNF inhibitor inadequate response. So they've tried Humira and Enbrel and Remicade, it just didn't work. And then they got onto an IL-17 blocker like secukinumab, and they did well. So all of a sudden, instead of one class of drugs, the clinicians had two distinct classes of drugs and gave us a lot more options. So the secukinumab looked good. So this is a study, which is better? A very good question. We face this question in clinic every week. So is blocking IL-17 with a secukinumab better than blocking TNF with Humira? Excellent question. And there have been a couple of studies looking, this is one that's just been published. This is the same kind of cumulative. These are funny, but every little dot here represents a patient. The fact that, so one of these lines, it's hard to tell them apart, right? Because they're totally superimposable. So one of the lines is secukinumab or Cosentyx. The other one is adalimumab or Humira. And essentially, there's no difference. So both in terms of X-ray progression and in terms of symptomatic control, the consensus is now that the TNF inhibitors, the IL-17 inhibitors are equally effective. Okay, so that is good. It also sometimes makes choosing a little more complicated. This, by the way, I mentioned that these studies are usually measured in the change in the BASNI, like how much of a difference it made in the back pain. This shows that actually it changes inflammation in the MRI. So if you, one of the things that I think the regulatory bodies and the clinicians have struggled with is these are very subjective symptoms, just to anchor it in pain. So if you actually measure inflammation by how much sacroiliac joint inflammation is detected on an MRI, you can show that they really change. And this study actually shows that, again, secukinumab and adalimumab are very comparable. So in that study, progression was low. And we always include progression as part of the discussion, as again, that's one of the long-term goals. In TNF inhibitor, this is a non-radiographic axial SPA, remember, has a less propensity to progress. In fact, many of our patients with the MRI positive, X-ray negative form actually never progressed to ankylosis. So the FDA and Health Canada were very concerned that we do a study long enough to show a difference. So this is actually a difficult study because it's a 52-week placebo-controlled study. That's an issue, right? Because you've got somebody whose pain is not adequately controlled, and they may be randomized to a placebo for 52 weeks. It's not a study. Many patients would not opt to go into that study, right? But the important point here is that secukinumab over 12 months is much better than placebo in the non-radiographic form, even though progression is not part of the discussion. Symptomatic control certainly is. Yeah, and this is ixekizumab. Next slide. This is just to show you one other comparator study. On the next slide, you'll see that here we've got adalimumab. I've got it circled in red there, and this is ixekizumab. It's an IL-17 blocker, just like secukinumab. And once again, they're very comparable. So this supports the conclusion that IL-17 block and TNF inhibitors are very comparable in terms of effectiveness. Next slide. Yeah, so this is ixekizumab, this IL-17 blocker working in non-radiographic axial SPA, the same conclusion as secukinumab, which is great. This is all very positive. So IL-17 blockers are very effective for psoriasis, for psoriatic arthritis. It turns out less so, uveitis, not clear, but certainly for inflammatory bowel disease, IL-17 blockers are not effective. So one of the concerns was IL-17 blockers have been tried for Crohn's disease and have not found to be effective. So there has been concern that if you use a drug like an IL-17 blocker and somebody's got unrecognized bowel inflammation, it might make it worse. The general impression is that's not the case. So this study compared IL-17 blocker with a TNF blocker, etanercept, and there was no unexpected rise in the frequency of inflammatory bowel disease. So at the moment, that seems to be a legitimate concern, but not really at the bedside. Yeah, so this is used in practice. Secukinumab seems to be a slightly higher risk, but the monoclonal antibodies seem to be effective. But it does become, when selecting between an IL-17 blocker and a TNF blocker, the presence of inflammation in the eye, the skin, or the gastrointestinal tract become an important part of that discussion because there's differential responses. So the two new classes on the drug are called JAK inhibitors. This is a drug called tofacitinib. This is a placebo-controlled study that shows that these again are anchored in patient-reported outcomes. You can see the top bar here is the drug, and here's the placebo at week 16. When the patients on placebo crossover, they catch up very quickly. So there's statistically and clinically a very significant response with tofacitinib over placebo. So then another one very closely related JAK inhibitor is called upadacitinib. I'm not sure who comes up with these cool names, but this one, next slide. As with tofacitinib, you can see here a 20% improvement or a 40% improvement on those two bars on the left. When you compare the active drug, which is upadacitinib or Rinvoq, it did much better than placebo. And on the right-hand side, you can see that besides these kind of subjective symptoms, like how's your pain feeling, if you look at changes in inflammation in the sacroiliac joint as defined by an MRI, that also provides objective evidence that the inflammation is improved with upadacitinib. And this again shows the use of prior biologics, as was the case when we just completed a study looking at patients that had tried previous biologics, either a TNF inhibitor or an IL-17 inhibitor. And you can see that regardless of which drug they were on previously, they did really well. They did much better than placebo. So this has really been good news for patients and clinicians that we now have basically three classes. We have the TNF inhibitors, we have the IL-17 inhibitors, and we have the JAK inhibitors. So this is all good news that we obviously are encouraged by the clinical research that's coming up with new targets. Okay, so I think I'll stop there. And because I hope there are going to be some questions that are rising from both the talks. And so Brenda, maybe you want to pass on some questions that have arisen.
A lot of really great information, and I just wanted to, and we do have some questions here, and
Good.
I'll invite Dr. Haroon to come back on the screen as well. Dr. Inman, for some reason your camera's not on, but I'm still going to bring you back onto the screen. I just wanted to just mention one of the things that I've taken away is that there are options, and the importance of options, because we know that up to 50% of individuals diagnosed become resistant to their treatments. And so one of the things that the CSA does along with SPARCC is we really advocate for new treatments consistently.
Yeah.
So some questions here. So we'll post some questions to Dr. Inman, and then we'll have some shared questions for all of our panelists here. So one question here is, for those of us who have UC, so colitis, are not allowed to take NSAIDs, is there anything else that can help with breaking through the pain, Dr. Inman?
Yeah, so in a patient with spondylitis and either ulcerative colitis or Crohn's disease, generally the NSAIDs are off limits. We don't want to the rheumatologists don't want to get into trouble with the gastroenterology colleagues, right? It's not a good time. So this is where this can actually accelerate the decision to escalate to a biologic. So if in the setting of colitis or Crohn's disease, if the back pain is persistent, Normally, we would give a thorough trial to an NSAID, but that's really off limits with colitis. So generally, that is what would accelerate a discussion to escalate to a biologic. And I would say, Brenda, that it's very important in terms of team management that the rheumatologists and the gastroenterologists work very closely with the patient. I mean, ideally, the fourth partner in that partnership is the family doctor who's quarterbacking. But I would say the family doctor, the patient, GI, and rheumatology should be in communication. Actually, that's in the EMR era and emails. We can actually communicate. We can follow patients anywhere in the province or the country, actually jointly with other specialties. But generally, in the situation behind the question, it would be, instead of an NSAID trial, it would be escalating to a biologic.
Interesting. Thank you for that. Another question here is for Dr. Inman. Can you comment on the long-term risks involved in biologic therapy? And is there any research into the time frame of being on these before your risks?
Okay, so it's a great question. Just so again, looking at the broad three classes. So if you look, there was a concern in the early days of the TNF inhibitors that they might confer a higher risk of lymphoma. This really came mostly from rheumatoid arthritis studies. When those studies were really carefully analyzed, it looked like it was the severity of the rheumatoid arthritis that conferred the risk. So if you compared equally severe RA patients who were or were not on a biologic, there was a higher risk. So it wasn't so much the treatment, it was the severity of the disease. I think that's been pretty much has been applied to PSA and psoriatic arthritis and AS as well. So secondary risk of cancer is always something we're cautious about. But if you look at large population studies, particularly in AS, it doesn't seem to accelerate. There are some very rare side effects when multiple sclerosis occurs in a very small percentage of patients. Unusual infections can occur. We always screen for tuberculosis and hepatitis B virus before we start. And I would say in terms of immunosuppressives, particularly in the COVID era, it's reassuring for our patients to know that drugs like the TNF inhibitors do not seem to negatively impact outcomes with COVID or even outcomes from a vaccination. So we do treat it cautiously, because if you got an infection that requires an antibiotic, it could be a urinary tract, it could be a ear infection, we hold the biologics. But so generally, the discussion has been dominated by infection risk and cancer risk. Just for completion, Brenda, there's the JAK studies, which is this is tofacitinib and upadacitinib. They brought in a question of cardiovascular safety. So it's a little more complex issue, but there was a study using tofacitinib in rheumatoid arthritis, again, not AS, in older patients, not our younger patients, and they all had significant cardiovascular risks, either smokers or high cholesterol. There seemed to be a higher risk of cardiovascular disease with the tofacitinib, the JAK inhibitor, compared to a TNF inhibitor. This is an important cautionary note. I wouldn't say it's not the only part of the discussion, but one practical implication would be if we're starting a biologic in a 55-year-old patient who might have had a family history of cardiac disease or is a smoker, we might be inclined away from a JAK inhibitor. Okay, so the cardiovascular side of this story is an important one, but it's and I think we're getting more experienced in answering the question.
Yeah. Thank you very much for that. We do have a question here. I think this is for Dr. Haroon. Can you please expand on the higher rate of AxSpA and HLA gene in the First Nations Northern BC and other tribes and families?
Yeah, so as I was explaining about the potential, that this is again a hypothesis, and it comes from, and it's the same is applicable for any of the genetic studies where you find a much higher prevalence of a specific gene in a population. A similar example is sickle cell anemia associated gene and malaria prevalence in Africa. So again, those are mirror images where if sickling of the RBCs tend to be protective against malaria invasion, right? So if you have that abnormality, although it is not great, but you're protected against malaria. So there's a survival advantage there. Similarly, maybe having the gene HLA-B27 has a survival advantage with many viral infections, and this is during the time of migration and while colonies were settling down in different parts of the world, migrating from one part to the other. Perhaps part of the population got wiped out because they were susceptible to a form of infection, and happened to be B27 negative, but because they were B27 positive, they survived and they ended up in one of the places. That's sort of the hypothesis. Now, why is there an association between B27 and AS? Again, we don't know exactly, but we're getting closer to, looks like we're getting closer. Perhaps having B27 enables the individual to present antigens. Some of these antigens look similar to antigens found in the sacroiliac joints. Maybe they look similar to antigens found in the eyes. Because it looks so similar, our immune system could get confused, right? And then the immune system maybe thinking it's getting rid of the virus, but actually it gets confused with the antigen in the eyes, attacks the eyes, and it causes uveitis. Attacks the SI joint and causes sacroiliitis, not knowingly but unknowingly. So that is called a molecular mimicry, and that might be the reason.
Everything. It's such a complex disease, and yeah, thank you for that, Dr. Inman. There's a question here that I wonder if you might be able to answer, and that is there research on using CBD and alternative therapies such as that for treatment?
Yeah, it's a great question. So cannabis is legal in Canada, so we can undertake such discussions without crossing infringing on the law of the land, which is great. There have been several studies, actually, in some of our colleagues at Toronto Western looking at osteoarthritis, not OA, about even the potential anti-inflammatory effect of cannabinoids like CBD and THC. So that's an interesting area in and of itself. Maybe these drugs have got some anti-inflammatory effects, but most of the discussion has been about pain control. So in our own clinic, we think there's a space, particularly when pain is the dominant issue, and we've done our appropriate management structures. Maybe we've tried a TNF inhibitor or another biologic, and pain control is remaining a challenge. Then having a discussion about CBD and THC is very useful. I can share our own experience. We don't have any systematic trials underway, which I think that would be an interesting question to look at. Anecdotally, I think we have some patients that usually oils rather than smoking. Smoking is not great if we actually think smoking is bad if you've got ankylosing spondylitis, but trying oils. Some patients say they really get a much better night's sleep. They sleep more restfully. And that's an important part of management of AS, that you get a functional restorative sleep pattern established so you wake up feeling better. So yeah, I think there's experience that it can benefit symptomatic control, particularly the pain level. We have no evidence at all that it is disease modifying.
Yeah, that's interesting. A lot of interest around this and alternative therapies and movement and physical activity, and Laura always says physical activity an exercise plays such a key role in disease management.
Right.
I'm just moving through some of these questions here. There's an interesting one, and that is, would there be any connection between the disease and early trauma?
That's a good question. So we don't really know. When we think about back pain, we kind of rather simplistically separate the patients into mechanical back pain and inflammatory back pain, right? The latter being spondylitis, the former usually being disc disease. Well, that turns out to be probably oversimplistic because even patients with some disc protrusion will have a little bit of inflammation around the disc space. We wouldn't advocate a biologic and such, but there is some inflammation. On the other hand, inflammatory back pain that we think of as kind of driven entirely by inflammation probably does have a biomechanical component to it. So this has been looked at, for example, in kind of the work people do, say heavy manual labor jobs versus sitting at a computer desk all the time, looking at whether or not if you load the sacroiliac joint, this has been looked at in Army recruits that are carrying heavy backpacks and loading their sacroiliac joints. So, so that's one aspect. Maybe low-grade chronic trauma or biomechanical stress can influence the course. The trauma question comes up, right? If you have AS or unrecognized AS and you're in a car accident, or you slip at work and land on your back, and then somehow it seems to accelerate the severity of your back pain, we often have to wrestle with those questions, like whether the injury, the trauma can actually play some kind of module. We don't think it would incite the disease. Would you agree, Nij? It might change the course. What do you think?
Yeah, it's immediately what comes to mind is, yes, I completely agree with what you said. What comes to mind is a patient who presented very recently to clinic and got, really stumped me. So this is a young person, let's say in their 40s or so, and then had a significant fall early this year, like January, February. Had absolutely no symptoms till then. And then after the fall, developed back pain. And obviously, it was considered to be related to the fall, but then it's not going away. It's been 5 months, 6 months, not going away. So an MRI was done of the spine to see if there was a fracture. And the spine showed a lot of inflammation in the area. So, Rob, these were corner inflammatory lesions in multiple levels. Yeah. So still, these are edges of the vertebral bodies where the typical sites of inflammation you see in the in spondyloarthritis, but it's not very specific, because if you do that in patients with mechanical back pain, you may see that. When you see more than 3, especially when you see more than 5 of those lesions, it becomes a bit more specific for spondyloarthritis. But still, because of that very clear connection to trauma and nothing before that, we initially thought, okay, let's give it some more time. But anyway, let's do an SI joint MRI as well. And just last visit, the MRI came back and florid sacroiliitis on the SI joints. So now what do we do? So then I asked, how is it? And patient is not taking much of treatment, 80% better already. But so 80% better, triggered by the trauma, but florid inflammation that is very classic of AS in the MRI. So we decided, okay, we'll just repeat the MRI in a year. If things are improving 80%, but let's not do anything. We will not label it as AS. But if this patient goes on to develop AS 2 years or 5 years from now, that's sort of an indication, maybe trauma. I don't know.
Yeah.
So far we don't have evidence, but basic science, a lot of studies looking at, for example, components of cartilage, components of bone that get exposed following a fracture. For example, so you get a fracture and suddenly something that was protected inside, was immune privileged site, gets exposed, the immune system sees it and then develops an immune response, and maybe that could lead to arthritis. So that's one possibility. So basic science does show that, but it's very difficult to prove in humans. Yeah.
We see that question a lot. Yeah. I'm just going to move over here to a question that was posed prior to, that's not in the chat here, and it's about how important is physiotherapy, and is there merit to chiropractic care?
Well, I think we don't, regrettably, we don't have the expert here tonight. She's just convalescing from an upper respiratory infection. But Laura would say, and I think with a lot of supportive evidence, the physiotherapy really is important for a bunch of reasons. First off, maintaining your posture. If your tendency towards what you want to maintain your posture as vertically as possible, we all tend to slouch, particularly looking at our cell phones and sitting at our computer screens. That's an important component. Secondly, you've got some evidence that active exercise actually can have an anti-inflammatory effect, actually can lower some of these inflammatory cytokines we're talking about. And then you've got a lot of secondary benefits. The study that Dr. Haroon led, showing that there's a cardiovascular risk component, like there's all kinds of secondary benefits from exercise, to keeping your cardiovascular fitness up. So I think there's very strong evidence that that exercise and physiotherapy is kind of a cornerstone of management, much more so than I would say is the case, say, from rheumatoid arthritis. Like it's really something about spinal arthritis that it really benefits from exercise, particularly, I think.
That's great. Thank you very much. I do see a question here in the chat. I think it's going to be a technical answer. It's I'm just mentioning it because I think we're going to respond to you after this event, and it's with respect to BCD 180. So we will respond to that after, because I think that will take quite some time, but I just wanted to acknowledge that we did receive that question. Thank you. Women's health is an area that is quite often brought forward with some questions around it. There's a question here. Is there any relationship between AS symptoms, menstruation hormones, and is there any insight that you could share or provide?
I'll give you a quick answer, and then Nigel can share a study that one of our fellows, Trish Ramalante-Renko, has just done about the role of sex in response to biologic. Just as far as the hormones, Brenda, we looked at the effect of oral contraceptives. Dharani Mahindra did a study in our clinic looking to see whether and we really didn't see a signal. Another big hormonal flux is pregnancy, obviously. And we know that besides hormonal flux, there's a huge mechanical load, I gather, talking to my spouse, on the sacroiliac joint during pregnancy. And labor and delivery puts a huge mechanical load on sacroiliac joints. As far as hormone replacement therapy in the menopausal years, we don't really have a lot of data. I mean, again, that's a different, in patients going through menopause are often past the most inflammatory phase of their AS if they're in their late 40s or 50s. So yeah, and the general sex bias of the disease, remember that AS is predominantly a male disease. Now, non-radiographic has a different sex bias, but it certainly provides a lot of clues that sex hormones may modulate the disease. Want to make a comment on Trish's study, Nij?
Yeah, I was going to share the poster, but she presented the poster at the American College of Rheumatology meeting just last week. And the conclusion was that female sex was associated with shorter biologic survival. And this has been consistently shown across many AS populations. Generally, males tend to respond better to treatment, and females have a lower response to treatment. Now, exactly what is the cause, we are not very sure. But fundamentally, if you look at the way disease presents, there are significant differences. So males tend to have a lot more progression, spinal progression. Females tend to remain more non-radiographic rather than AS. And even if female patients develop AS, they don't progress to spinal fusion and bamboo spine as fast as males do. But when it comes, which is a good thing. But when it comes to treatment, the response is not as good in females. They tend to lose efficacy faster. They have lower chance of response to treatment as well early on. So if you look at inflammatory parameters, you see that CRP is much more elevated in men than women. So that also is good from a female perspective, but is that the reason why an immunosuppressant is not that good in females? Maybe inherently they have less of an immune inflammatory response. It's more of maybe the pain pathways that get affected more rather than the immune inflammatory response. So maybe there's a different kind of treatment that will be better suited for women. All of these things are, good questions, but no definitive answers. Yeah.
That's great that these studies continue. I'm just looking at the time. We just have a few minutes left, so I'm just going to go to one final question. For those questions that have not been answered, there are several. We will respond to you. So thank you for those submissions. There is a question here that is, how can I, as a spouse of someone that has been diagnosed for a couple of years, help? I'm struggling with what I can do with daily things like energy. pain, attitude, etc.?
Yeah, I mean, that's a great question. Most chronic illness involves both parties, and whether it's rheumatoid arthritis or dealing with any chronic illness. And so it's a team effort. And I think as rheumatologists, we try to keep the symptomatic burden of the disease as low as possible, right? We're trying to get the pain and the fatigue and the stiffness as the lowest. But that being said, we don't always get there. And it's not unusual that there's an emotional burden that comes along with that. There's kind of, it can be tendency towards anxiety and depression, discouragement and despair when things aren't going correctly. So, and that's obviously affecting both the patient and the spouse. Yeah, I think sometimes working and having the spouse come to the appointment with the rheumatologist is very useful. So everybody is on the page on what the treatment goals are. And I think the CSA is a great example of a support network because sometimes the caregiver or support person is actually carrying a lot of the burden of functional activity, particularly if it's a very active stage or it's late stage AS, like just picking up the groceries or picking up the kids from school may fall on one spouse more than another. So yeah, I think it's a really good question. I think that Dr. Haroon and I both realize that having seen patients, the emotional and so the psychological side of this disease, we tend to see a very small little snapshot of a patient in the clinic, right? We try our best to get a comprehensive picture, but the patient returns to an environment that could be quite discouraging, and we try to be as sensitive to that as possible. Do you want to add something there, Nich?
Yeah, I think other important thing to also remember is that, and it's a chronic inflammatory disease. Yes, there is no cure to it, but there are so many options for treatment now. The outcome is infinitely different from, let's say, patients that we have seen in 20 years ago. So absolutely, great hope for treatment, for outcomes, for prognosis, no doubt about it. The other thing also is there is a difference in how we see the disease depending on how many years it has been since a diagnosis was made. So if you look at quality of life studies, and this goes across all chronic inflammatory diseases, quality of life and functional index and all of that is very high impact on the patients in the first 2 years, 3 years, 4 years. And then patients realize that, oh, this is not that bad. Yes, I have a little bit of difficulty here, a little bit of difficulty there, but the treatment is great. Pain can be controlled. It may not be 100%, but I can get to 80%, 70%. And then actually the scores improve once that realization happens. So it's very important to be supportive and be there for patients in the initial years when they're getting adjusted to the new reality, the new diagnosis. But after that, there can be bumps on the way, no doubt. There could be a time when 3 years, 4 years down the line, the drug starts to fail, and then again you go, feel that what is happening. But then there's so many options available, yeah, and even more are being discovered. Yeah.
That's such a great message of hope, and especially as we wrap up, I'm just going to ask you to both stay on the screen right now. I'm just going to share my final few slides right here.
Great.
I think that we can see that here. I just wanted to say, thank you to the supporters of the CSA, and in full transparency and disclosure here, we just wanted to acknowledge the funders of this webinar series, and we can't do this work without our partners, and there are so many gracious organizations and individuals that support people living with spondyloarthritis, and we just want to express our gratitude to all of you. And so that really concludes our session today. I want to say thank you to Dr. Inman, to Dr. Haroon, and a special thanks to Laura Passalon, who has extended her expertise here today, even though she's not here personally. We are so grateful for what you do for so many Canadians from coast to coast, and we're really grateful for the messages of hope, but also for all the insight and the facts. And when you're dealing with such a complex disease, the facts really matter. And so thank you for continuing to advocate for Canadians. We really appreciate it. And thank you all for joining us here this evening. For those who have not had a response to your questions, we'll be sure to reach out to you in the coming days. Thank you very much, everyone.
Thank you, Brenda.
Thank you. Good night.
Bye.